Mind the Gap webinar series. This series explores research design, measurement, intervention, data analysis, and other methods of interest to prevention science. Our goal is to engage the prevention research community in thought-provoking discussions to promote the use of the best available methods and to support the development of better methods. Before we begin, I have a few housekeeping items. You can submit your questions during the webinar by clicking on the question mark in the WebEx toolbar. Please direct your questions to all panelists. We will open the floor to questions that have been submitted via WebEx at the conclusion of today's talk. The slides and video recording will be posted on our website, prevention.nih.gov/mindthegap, in approximately 1 week. You will receive an email when they are available. Lastly, we would appreciate your feedback about today's webinar. Upon closing the WebEx meeting, you will be prompted to complete an evaluation. We would appreciate your feedback as it will help us improve this webinar series. At this time, I'd like to introduce Dr. David M. Murray, Associate Director for Prevention and Director of the Office of Disease Prevention.
Thank you, Marie. Today's speaker is Dr. Walter Dempsey. Dr. Dempsey is an Assistant Professor of Biostatistics at the University of Michigan. His current work involves 3 complementary research themes: experimental design and data analytic methods to inform multi-stage decision-making in health, statistical modeling of complex longitudinal and survival data, and statistical modeling of complex relational structures such as interaction networks. His research focuses on the design and application of novel statistical methodologies to make sense of complex longitudinal survival and relational data sets. This work informs decision-making in health by aiding in intervention evaluation and development. It's my pleasure to welcome Dr. Dempsey.
Hi. Let me start by thanking Dr. Murray for introducing me and everyone for the invitation to talk on my work and how it relates to decision-making in mobile health. So the talk today is titled Joint Models of Longitudinal and Time to Event Data for Informing Multi-Stage Decision-Making in Mobile Health. The goal of the talk is to discuss both mobile health and joint models of adverse event data and longitudinal data, and how we can think of these models that have existed in statistics and these methods that have existed in statistics for a while and apply them in mobile health, with the ultimate goal of either developing interventions or assessing interventions in these settings. The way I thought I'd design the talk is around a couple key points and then drilling down on them. So first, a very brief introduction into mobile health. I'm assuming that many of the attendees are at least familiar with mobile health, but I thought I'd give an introduction to how I think of mobile health, both in terms of the data collected, but also how that data relates to informing adaptive interventions. I then discussed some methods, joint modeling methods. I didn't want to go into too much mathematical detail. My goal instead was going to be to focus more on 2 approaches, one model-based and one design-based, that allow us to assess different questions of interest. And then I thought I'd do 3 main case studies around different questions you might be interested in answering. So the first was assessing association. The second is defining risk strata, and I'll discuss that as it relates to a micro-randomized trial. And then the third is assessing treatment effects and how to use these models to do so. I'd end with a couple comments about recent methodological developments for joint modeling in mobile health. The goal there being to state that, of course, we don't have methods for everything, and trying to draw out and discuss some of the key problems we're trying to address right now on the methodological front and how it relates to scientific questions of interest. So what is mobile health? There's many different definitions. I here just pulled up one of the definitions from the Foundation for the NIH, in which it defines mobile health as the delivery of healthcare services via mobile communication devices. More broadly speaking, I think of mobile health as the use of mobile phones and wearable devices in medical care broadly. There are different situations in which mobile devices are used in different ways. Sometimes it's used purely as a mechanism to deliver an intervention, and other times, and the focus of this talk is when you're using mobile devices and wearable sensors to both collect information on the individual, but also use that collected information to decide what interventions to provide and when. So the first points I'd like to make are around the type of data that we collect in mobile health, and these can broadly be broken into two components, the first being active data. So active data involves explicitly asking participants for information, preferences, and or opinions. So in the mobile context, you can think of an individual with their phone, they've downloaded an app and they're participating in some study, say a smoking cessation study, and they're going to be pinged through their phone to answer some self-reports over the course of that study. And these are referred to as ecological momentary assessments. I'm going to shorten that to just EMAs for the remainder of the talk, and we're going to discuss there are different types of EMAs one can provide. There are administrative. These are things like fixed time self-reports, daily diaries. There are random EMAs, which one can think of as randomly within some block of time. I'm going to ask about your current context and ask you several questions. And then there are event contingent, which are given I've seen it or sensed an event has occurred, I'm going to then trigger an EMA. And I distinguish among these, and we'll see why later down the road, but these are just three of the types of EMAs one can think of. And so one of the things that is often not highlighted but important to think about is with active data, there is a question of attendant burden and intrusiveness. One might want to ask over 20 to 30 questions, do a sort of a battery assessment via the EMA. However, if we're not paying the participants a lot of money, there's a chance that they're not going to complete a lot of these EMAs. And so the question is, which behavioral constructs of interest are we really trying to assess, and which ones are most important for informing decision making? And so we should prioritize those, and we should think about the trade-off in terms of the number of questions asked as well as how often they're asked when we're thinking in terms of decision making. The latter type of data is passive data. This is, one can think of as just the wearable sensor data as well as the mobile device data that is being collected on the participant, and the participant has little awareness of the data collection effort. While they might have little awareness of the data being collected, they of course must wear the devices and have their phones on them in order to collect that data. So while it's passive in the sense that once they're wearing the device, they don't need to actively respond to self-report, it's not passive in the sense that you have to have the individual actually wear these devices. And so again, we are interested in collecting this type of data, but there are still questions around how many sensors and what sensors are most important for decision making. So this is a picture of an individual in a recent Sense to Stop study. We were interested, and I'll discuss this more in depth down the road, but we were interested in trying to collect information about the current level of stress, and we used different sensors to do that. So we used 2 wrist-worn sensors as well as a chest sensor. These, of course, have high attendant burden, and so one can think of settings in which if you ask an individual to wear all of these devices over the course of multiple months, it's just not going to happen. And so we need to be careful in terms of when we say we're going to collect passive data, what do we actually mean, and is it feasible? And so here we ran a study for 14 days, and that was both chosen because of the science around smoking cessation, but also because we thought it was a reasonable number of days that we can ask a participant to wear these sensors. So going with Sense to Stop again, the main point here is while mobile health data is collected and there's a lot of information being accrued on the individual, we should always go back to why are we collecting that data. And so going again with the example of Sense to Stop, the goal there is to collect this information in order to intervene on the individual. The interventions here are provided in order to relieve stress and reduce stress, which we think of as related to an adverse event of smoking. And so what we're going to do is use sensors and EMA to monitor stress continuously and decide whether and how to intervene based on the current level of stress. We're going to deliver that intervention as soon as stress occurs in the person's natural environment. not only are we going to monitor stress, but we're also going to use the phone and things like the GPS data on the phone to monitor the context. One can think of a lot of settings in which it is probably inappropriate to provide an intervention via the phone. So the simplest example being, if I can detect the individual is currently driving, I should not be sending them text messages over the phone. There's also other situations like if they're at work, if they're busy, maybe they're not as receptive in that current moment. These are things that we're going to monitor. And so there's this picture that my colleague Billy Nahumshani uses in which the goal of wearables is to actually have a therapist in your pocket who comes out and looks and observes the context in which we might provide interventions. But of course, we can't have a therapist in our pocket. We can just use mobile devices and wearable sensors to collect that information. So the last thing I'll say before moving on to the joint modeling aspect is, why are we collecting so much data? So not only why are we collecting that data, but why so much? And again, this comes back to the goals of decision making. And the goal here is the delivery of the right type of support at the right time while minimizing disruptions. We refer to these as JEDIs, or just-in-time adaptive interventions. The goal is to have data-driven decision-making, so we're going to decide both the right type of support and the right time by using the mobile data that we've collected. The minimizing disruptions is the goal of not providing it in the wrong moments, but also trying to balance between maximizing the therapeutic effect of these interventions while minimizing attendant burden. So trying to not have too many EMAs within that day to collect enough contextual information, trying to not have the individual wear too many sensors while collecting enough contextual information to provide actual interventions. So to do all of this and to build JEDIs, there's a lot of questions that one needs to answer along the way. And I'm going to both argue and demonstrate how joint modeling plays a role in this sort of process. And the high-level reason that joint models play a role is in a lot of settings, smoking cessation being one, there is an adverse event that we care about. It's typically the distal goal is to lower that risk of the adverse event. And there are a set of biomarkers one might be interested in. And so the first goal is typically to assess how strong the association is between a biomarker and an event of interest. The reason being, a lot of the interventions target that biomarker. So if we think about sense to stop, we're targeting the biomarker of behavioral biomarker of stress. And the reason is because we assume that there's a strong association between stress and the risk of lapse. So reducing stress should reduce the risk of lapse. Another reason we might be interested in joint models is because we like to discriminate between patients who are currently at high risk of an adverse event in the near term versus those who are at low risk in the near term. The reason being, again, we want to minimize attendant burden, so we might only want to provide interventions when they're at high risk. And the last is, we have this movement towards digital phenotyping, which is trying to use all this information collected in order to build profiles of the individual in real time at this given moment. And the question is, are these biomarkers useful for decision making? So just a quick example of decision making as it relates to an adverse event and a biomarker. Here we have HS, which was Dave Gustafson at the University of Wisconsin built this. It's a smartphone application to support recovery from alcoholism. It's a mobile phone administered. And what happens is individuals at baseline record high-risk locations. So these are what we're going to monitor through the phone. We're going to monitor their GPS and know when they're in these high-risk locations. And then we're going to potentially intervene and in these moments when the GPS initiates an alert to ask if the patient wants to be there. Again, the reason being, we think of these high-risk locations as being associated with high risk of an event, and so we're going to intervene in those moments. So before I move on to discussing joint models as it relates to decision-making, I just sort of need to discuss the methods around joint modeling. I already mentioned all these research questions, but I wanted to state them one more time. There are multiple research questions you might be interested in. All of these are going to involve some type of joint modeling problem. So the first is, if you have an adverse event, but if maybe it might be distal, and so I want to affect some biomarker, the primary goal will be to display a strong association of that behavioral biomarker with the risk of the event. And so we might have questions about the association. The second type of question is a predictive question, which is, can we improve predictions of the risk by considering the behavioral biomarkers? So trying to build models of, joint models allows us to build predictions of an event in the near term. And the third, again, is the treatment effect analysis, which I mentioned. But here I just like to highlight that we typically want to understand not only the effect of treatment, but what pathways that treatment affects outcomes of interest. So one of the goals may be to disentangle both direct effects of the intervention on the risk versus indirect of treatment on the risk of the event through the biomarker. So we might have a treatment which affects stress, which therefore if we lower stress lowers the risk of the event, but it also might directly just affect the risk, and disentangling those effects is important for the purposes of understanding how our treatments impact these processes. So I'm going to introduce two ways of building methods for joint models. The first is related to standard longitudinal and survival techniques, so I need to start there. If you're familiar with longitudinal data and analysis of longitudinal data, I apologize if this is a very simple slide, but it's a place we all should start, which is we have repeated measurements on the individual, so we're thinking here of the EMA component for now. I have repeated EMAs, which are measuring different outcomes of interest. And how do I model those repeated measures? Well, one way is through a random effects model. And here we have a linear mixed effects model in which we have an outcome Y, we have fixed effects X beta, and then we have the random design matrix and the random effects here. And the idea is that you're going to capture the positive correlation within the individual over time, the measurements on that individual. So visually what's going on, this is a little bit easier of a slide to understand. What's happening is we have the fixed effects, which is a population level average, and here it's a linear random intercept slope model. So we have a positive fixed effect, seeing a positive increase in the longitudinal outcome over time on average across patients. But of course, we have heterogeneity among the patients, and so the random intercepts and slopes are accounting for that positive correlation and that differences among individuals. So for this subject 2, we see that we have a similar trend positively, but with a different intercept. But for subject 1, we actually have a negative association, or sorry, negative relationship over time. And so that's going to be captured by the random intercept and slope. The other component of joint models of longitudinal and survival data is the survival models. And here I just wanted to introduce some notation for those not familiar with survival analysis. The idea extends to recurrent events, but here I'm focused on a single event, a time to event outcome TI star. The key issue, or one of the key issues in survival analysis, is that sometimes we don't observe that outcome. So if we're thinking again of sense to stop, a smoking cessation study, the time to event is the time until first lapse. The issue is an individual may end the study before we observe that lapse, and so we have a censoring time CI. And so our observable data is actually going to be the minimum of those 2 times. And so the goal is valid inference about the time to event outcome when we have censored observations. There are many components to and methods for survival analysis. The ones I'm going to focus on here are related to modeling what's called the hazard function. Again, if you're familiar with it, that's great. If you're not, the idea behind it is as follows. So I have a survival function which I care about, which is the probability that the event occurs after some time t. So this is something like, in the sense to stop example, the probability the event will occur after day 5. The hazard function is actually an instantaneous risk of the event. It is related to, if I know the event has yet to occur at time 5, what is the instantaneous probability that the event will occur in the next small window of time? And many models for survival data is focused on the hazard function and building models for the hazard function. The most simple of which is the relative risk model. And so a lot of joint models focus on extensions of this relative risk model, which is why I introduce it here. So the relative risk model is as follows. You assume a proportional proportional hazards model in which there's a baseline risk associated over time. So this is just a function of time itself, and it's shared among all individuals. And then on each individual, I measure a set of covariates, WI1 through WIP, and I'm just going to adjust this baseline risk ratio by multiplying it by e to the gamma times this W. So on the log scale, you can think of it as additive. The hazard function is additive on the log scale, so the covariates are just adjusting the log hazard function. One way to fit these models is through the Cox proportional hazards model. This is going to take the relative risk model and just avoid modeling this complicated baseline risk. And so this is the mathematical form. I don't really want to highlight it too much in depth, but the main idea here is that we can build simple algorithms for fitting the model and assessing effects of both baseline covariates and treatment. So here is a very simple example in which I observe survival times on each individual, potentially censored, and I observe both covariates that are baseline covariates, so gender and age, as well as treatment. And this type of model allows us to assess the association of baseline covariates with the outcome of interest here, which is the survival outcome. So this is just to highlight that example. Now, the problem with survival analysis for the purposes of mobile health is that we actually observe time-dependent biomarkers. So I'm not just observing baseline age and baseline gender, I'm also observing the EMAs are actually measurements of behavioral biomarkers over time. And there is sort of a distinction between two types of biomarkers. One is called external or exogenous, and the other is endogenous. So external time-varying biomarkers are things like weather, where your outcomes, the outcomes of the survival outcomes on the individual, the trajectory of weather is not affected by the occurrence of the outcome. So the fact that I know someone died does not affect future weather patterns. Of course, those can be included, and those are very easy to include, or at least easier to include in survival analysis. What's much more difficult to include are endogenous ones in which the future trajectory is affected by the fact that the individual has not smoked. So in the case of stress and smoking, the fact that I know the individual has not yet smoked is going to impact the dynamics of stress into the future. But there are ways of extending the model to handle these types of things. So the first extends it to external. So I take the Cox model and I can easily extend it to an external covariate by just having the so this was my first term that related to baseline covariates. And what I'm going to do is I'm just going to add an additional term, which is the instantaneous risk at time t is a function of the current value of the external covariate. So here, if we're thinking of weather and we're thinking of, let's just say smoking still, so we're thinking of the probability of lapse. Potentially it might be associated with if it's cold or not outside. And so this is going to adjust the relative risk by just what is the current weather at that time times some alpha. So the alpha is assessing the association or the relative risk by 1 unit increase or decrease in y. The problem with this for endogenous covariates is it doesn't take into account this issue that knowing the individual has survived up till time t is going to impact the future trajectories. So if we're thinking back to the mobile health context, most of my EMAs are related to endogenous covariates, endogenous time-varying covariates. And so what we need is a joint model both of the survival outcome as well as the trajectories for my endogenous time-varying covariates. And so this is what motivates the joint modeling framework. So from a methodological standpoint, the motivation is actually quite classical, which is I have some time to event outcome of interest, I have some endogenous time-varying covariate, and so what I want to do is I want to understand the association between these two, which requires a joint model for longitudinal and time-to-event data. It's a very intuitive idea. What we're going to do is we're going to marry the linear mixed effects modeling, the longitudinal data analysis models with the survival models into a joint model. So at a very, very high level, that's the one sort of method one that I'd like to sort of talk about today very briefly is this shared random effect model. So the idea behind it is we're going to take the existing longitudinal models and the existing survival models and try and marry the two into one single joint model. What it assumes is a latent trajectory. So the basic idea is that you assume a latent trajectory, which is typically referred to as the true biomarker trajectory. So we have true stress or true craving over time, and you build a longitudinal model for the biomarkers given the true trajectory. And then I take that true trajectory and I use it inside of my survival model. And what ends up happening is you assume a conditional independence between the two processes given this true trajectory. And then what typically is required is to have good models for the actual trajectories of these longitudinal data. So mathematically, just to highlight it, it's going to look very similar to the extended Cox model in that what we're going to assume is a relative risk model that's impacted by this MIT, which is the true trajectory. So before it was YIT, and now here we're inserting the true value of stress or the true value of the behavioral biomarker into my risk model at time t. And it's going to, but what we're going to do is we're going to capture the fact that you're surviving past some time by actually modeling out what MIT looks like. And what does that model look like? Well, it's a linear mixed effects model, at least in this example I'm presenting here. One can get more complicated and try very complicated parametric models. If you have an outcome, so one question might be, well, my ecological momentary assessments are ordinal outcomes or they're binary outcomes, so I don't have a continuous measure. That's okay. We can move to generalized linear mixed effects models to handle that. The key point, and the reason I'm focused mostly on these simple models, is the key point is you just need to have a model for the trajectory itself, and what is the appropriate model is a question for the particular data set you are looking at. Now, this is method one. The benefits of method one is if I have good models for my data and I have a good model for my survival or event outcome, I can hopefully do a good job of combining them using the joint modeling framework of method one. Now, the problem with mobile health data is it's quite complicated. So if I'm thinking of ecological momentary assessments, I might have a lot of different measures over time. The dynamics of those processes might be quite complicated. So if I'm thinking of craving, the trajectory of craving over time is a quite complicated process. And so I might not feel very comfortable assuming I can do a good job in modeling out those dynamics. And of course, one can say, well, I'll just build a more complicated model of those dynamics. The problem being in a lot of situations in mobile health, we have a very complicated dynamic system, but I only have 50 observations in terms of 50 people in my study. And so how do I deal with that? Well, there's a second method which was introduced by Schiffman and Rathbun. I think this is a paper from 2013, and I'd like to highlight it because it's a slightly different approach, and it requires fewer assumptions but slightly different setup. So the idea here is to use the randomness in my EMAs instead of modeling assumptions. So I'm going to build what's called a design-based estimator of the association between the time-varying endogenous covariates and my event outcome of interest. Now, what this requires, and the reason this makes sense, again, is because I have very complicated dynamics for my underlying behavioral biomarkers. It allows me to avoid that modeling problem by using the randomness in the EMAs themselves to estimate these effects. The one thing it does require is you to measure the actual value of the time-varying covariate at the event outcome itself. So what this requires is knowledge of the event outcome the measure of the covariate at the event time itself, which may be difficult. But the point here, and the point I'd like to make, is that this design-based approach or randomization-based approach does have some benefits, and the benefits are just illustrated here in a very simple setting in which I have misspecified my joint model, but the randomization-based inference is unaffected. So if my joint model is misspecified, I may have a huge bias in my estimate of the association. And again, it might be an upwards bias, which means I might be observing a bias which is due to model misspecification. And so the randomization-based approaches allows us to avoid this problem. Again, this comes at a cost of needing to know the value of the time-varying covariate at the event time as well. But the point is, these models that were proposed is an alternative perspective and allows you to get a different method for estimating the effects of interest. So I've highlighted, so far I've highlighted two different methodological approaches to estimating the association. So let's assess that association. Why are we caring about this question of assessing association? Well, it comes back to decision making. The goal in a lot of these mobile health settings is to intervene on some interventions aimed at a biomarker of interest. The argument going that if I provide interventions that reduce craving, this will reduce the risk of substance use. Or if I provide interventions that reduce stress, this should lead to a reduction in the risk of lapse in the near term. And so what you need to have is as evidence that of a strong association between those biomarkers and the event and outcome of interest. So this is where the joint modeling comes in from an intervention development standpoint. So I'm just going to highlight here the results of a smoking cessation study that was in the Wrapup paper. Here, the treatment itself was providing a patch, nicotine patch or not, so that's the 0-1 treatment. And what's measured via EMA over the course of the study is a couple things. The two I'll focus on are craving and negative affect being a summary of several self-report questions by doing some factor modeling. But the goal here is just to show that we can assess that association between craving and the event outcome via this randomization-based methodology. And so we have an estimate of 0.4234. This is the effect on the relative risk when we look at changes in craving, and the p-value being quite significant. So this would suggest, again, this would be evidence used to say that I should be building interventions aimed at craving and using this as evidence for why I'm going to focus on this particular thing. So while we see, I might want to build interventions focused on positive affect, here we see that positive affect, at least from data from this study, there's not a very strong association between the positive affect and the event outcome of interest. We have a p-value of 0.33. And so if one were to ask what types of interventions should I be looking at developing and what biomarkers should I be targeting, this would be preliminary evidence to suggest that craving and negative affect are the things that we should be targeting in terms of proximal, just-in-time adaptive interventions. So given time constraints, I want to move on to a different type of decision-making problem in which these joint models occur, and this is in building predictions and or classification algorithms. So the first is in building predictions. So we might be interested, or one might be interested in building predictions of the probability that someone will lapse in the near future. Now, we can use machine learning algorithms to build those predictions, and one might be interested in doing so. The issue with machine learning predictions is a lot of the time we're interested in why we're building, why the risk or why the probability is high. And so when we ask questions related to why is the probability high, we're trying to say, well, is it because of some particular behavioral biomarker? And if so, then we know which behavioral biomarkers we should be targeting with interventions. So this is what's referred to a lot of the time as interpretability of our predictive algorithms. And so the idea behind method 3 that I'll introduce very briefly is to use latent variable approaches to build interpretable predictive algorithms. And the reason we want interpretability is because we're trying to build output that one can use to decide what types of interventions to provide in the moment. And so I'll just highlight this from a practical perspective in a recovery support services study. So this was Christy Scott and her team at the Lighthouse Institute run multiple studies, but this is one particular study of substance users in Chicago. And what we were interested in building was using all the mobile health data and trying to build predictions of the 30-minute lapse probability given all that data, but summarizing it into interpretable features. The reason being, if we know why we're having high probability of lapse, we might actually know what types of interventions to provide. And so here in this particular example, we have risk and engagement, and so what we're seeing is we're trying to break down this probability, this prediction, into interpretable risk due to the risk and interpretability due to engagement. So are we predicting it's high because of high engagement or low engagement? And this will allow us to figure out what types of interventions to target. The question that one might ask is, well, is predictive accuracy improved by using such interpretable joint models as opposed to more machine learning approaches? And this is just to show, at least in a very, very quick way, that our predictive accuracy is actually improved by using latent variable approaches and behavioral theory to motivate these predictive algorithms. So it's actually a benefit to use that to use behavioral theory to guide these predictive algorithms. And actually the joint modeling approach allows us to build very accurate predictions of these quantities of interest. The other component I thought I'd talk about very, very briefly is just the classification question, which is, suppose I now know that stress is something I should care about. I still want to be able to bucket individuals into high or low stress, or has stress or not has stress, and the reason being that I want to intervene in real time based off of those classifications. And this is just to highlight again the Sense to Stop study, in which we've gone through the process of building that strong association, and now we're going to intervene on stress. And so this is just to lay out the map of how we think about how stress leads to deciding if the person is stressed or not. We'll adjust our intervention protocol appropriately. So this is what we call a stratified micro-randomized trial, and the goal being that we're going to stratify the randomization probabilities based off of whether the individual was currently classified as stressed or not. And so we're going to be using the models as inputs to stratifying the randomization probabilities. So the last thing I'll mention before moving to just current work is assessing treatment effects. And the Sense to Stop study just ended, so I had hoped to have results there, but I'll save those for another day, and I'm happy to talk about extending methods in those directions. But one might be interested in, I've run a trial, a mobile health trial. How do I assess the impact of my interventions? And the nice thing is that the joint modeling approaches allows us to answer questions of treatment effects. And so the first question might be, how does treatment affect the relative risk? And so we can go back to method 2 using the randomization-based approaches and just throw that into my relative risk models. And so we see here a non-significant p-value, which suggests that, at least in this particular study, the treatment was not statistically significant. But we can also, and this is current work, the treatments we're providing in a lot of mobile health contexts are not just baseline treatments receiving nicotine patch or not. We're also interested in time-varying treatments. And the nice thing here is we can extend this methodology to address that question by incorporating time-varying treatments and how past treatments may impact current levels of risk. So I'm just trying to be cognizant of time. It's almost 11:40. I'll just end with two current problems we're working on and current extensions of joint models in mobile health. The first is actually in Sense to Stop. So I mentioned very briefly that joint models are typically built in which I observe the event outcome of interest, except it might be censored. Now, what's happening a lot in mobile health is we might observe, instead of just the event outcome, we might get multiple noisy measures of that event outcome. So in the case of Sense to Stop, we have smoking episodes, and we actually get to measure through sensors hand-to-mouth gestures over the course of the study. If we were in a perfect world, we could get full labels of the smoking episodes and which hand-to-mouth gestures we are observing are actual smoking puffs. But we don't. We actually observe a sequence of measures. So first we observe a machine learning algorithm output, which is telling us when hand-to-mouth gestures are occurring and giving us some signal at given times of the algorithm thinks that an event has occurred or not. We have random EMA, which also incorporates some level of information about did I smoke in the past, yes or no, and giving us a rough estimate of when the person smoked. We have event-based or event-contingent EMA, which is the individual coming in and actually saying, I smoked roughly 5 to 15 minutes ago. But again, this requires the individual coming in and providing that information, which early on in the study might be reasonable to say that they're going to do, but later in the study, due to burden, they might stop doing. And then we also have end-of-day EMA, which is the administrative or daily diary style, where at the end of every day, they provide some level of information about this. And so the current work we're doing is trying to figure out ways to combine these pieces of information to build joint models for understanding the impact of treatments, as well as building associations from this type of data. And so the approach we're doing is a multiple imputation approach. So this is current work in mobile health is how to combine multiple data streams in order to build single joint models. And the idea here is, again, to use measurement error models to do so. So the idea would be that we have these 4 different measures, and we're going to combine them through multiple imputation. So we have some uncertainty, which at least, let's say, in the final event, which this is a true event, because we have lots of signal, we actually can know that this is a true event. But in earlier events, we only have very weak signals, and so we have to, in the multiple imputation, account for that uncertainty. The second topic, which I'll very briefly mention, is how to incorporate sensors into joint modeling. A lot of the joint modeling approaches in the biostatistical literature focused mostly on biomarkers, which are measured intermittently. Ecological momentary assessments fit in that kind of thinking quite naturally. However, we now also have sensor data, and how do we marry the sensor information we're collecting with the ecological momentary data, and we're building methods to incorporate sensors. And right now we're working with a group who's focused on so the events are recurrent events of distress in a suicidal inpatient study, and we're getting sensor data of electrodermal activity as well as accelerometer data over the course of that window of time. And we're trying to answer that question of association, but here the association has to do with how do we process and map sensor data onto the risk. And the way that we're doing that is using sort of functional data approaches, which, again, I don't want to get into. The general idea, though, is to continue to use the joint modeling framework, but trying to deal with the fact that sensor data is quite both noisy, but also the relationship between sensor data and the relative risk is a little bit more difficult. So I'll conclude now and definitely open everything up to questions. The point I'm trying to make in this talk was 3 things, which is we have in mobile health typically longitudinal data, but also usually adverse events of interest in a lot of settings, both substance use, smoking cessation, suicide studies. In many areas of application, we're interested in that relationship between the longitudinal data and the event outcomes of interest. This is all in relation to building and estimating and understanding intervention effects. So it's in different stages of the intervention development process, everywhere from assessing the association to inform what biomarkers to target, to defining risk strata for micro-randomized trials, to estimating treatment effects in post-study analysis. Now, while we can do this in many situations, there's still novel methodological problems we're addressing now. So this comes with measurement error as well as incorporating sensor and EMA at the same time. But we're sort of on the trajectory towards having models to inform multi-stage decision-making in mobile health. And with that, I'll end. I'd be happy to answer any questions that you have now, but I'd also highlight that I'm part of a lab on dynamic decision-making at the University of Michigan, and if you don't have time to ask questions now, I'm more than happy to answer via email as well. So with that, I'll end. Thank you so much.
Thank you, Dr. Dempsey. Very interesting presentation. A number of questions. If you would, could we go to either slide 26 or slide 33? Sure,
26.
Okay. So, in fact, this one might be identical to 33, with just different things highlighted. But let's talk about this slide for a minute and ask a few questions about it. With these complicated models, one of the kinds of questions that users are always interested in is, what the heck do those estimates mean? How do we interpret the coefficients? Everybody understands that I calculate the z-score by dividing the estimate by the standard error, and I can look up the p-value for a z in a table, or it'll print out in the output. But how do I interpret the estimate? So take the treatment effect estimate, for example, here in this slide. It's 0.2129. What does that mean?
Sure. Let's keep 0.2129 in our head, and I'm going to move to a slide that allows me to talk about the math for a second, if that's okay.
Okay.
Just to talk about it with less English and at least an equation in front of us, so we can talk about it. So let me just stay on this slide for a second. Now, what we end up modeling is what's called the relative risk. The idea here is that you have a coefficient in front of your treatment. So there it was 0.2129. And the idea is, and the issue is, that over the course of the study, even if I didn't provide treatment, the risk itself, the baseline risk, is going to change. So we can think of a smoking cessation trial. You know, if the people are high, let's suppose a highly motivated population, on day one, regardless of treatment, individuals are very unlikely to lapse. The reason being that they're highly motivated, they really do want to quit smoking, and so we're going to see a baseline risk which is quite low. Now, over the course of the study, you know, by day 10, the relative risk, or the baseline risk, is going to move up. So we're going to see over the course of the study just that the individuals are going to become more and more at risk, potentially, you know, in this scenario, over the course of the study. What the parameter that we estimated related to treatment is doing is adjusting that baseline risk by a multiple. So it's taking E to the 0.2129, which off the top of my head, I don't know, so I apologize, but one can calculate. And it's
1.237.
There we go. And it's adjusting that baseline risk appropriately. So the key distinction between these models for event data and your more traditional regression analyses is you're doing so on a this is why we call it the relative risk model. And so even though it's a constant, it's adjusting a different baseline risk over the course of the study. And so it's that multiple is what you're getting adjusted by. We can keep going, and hopefully that at least provides some level of intuition.
Well, let's go back to slide 26, where we started.
Mm-hmm.
So you're telling us that the 0.2129 is a log relative risk, and if we exponentiate, we get 1.29 or so, 2.3, something like that. So that you're telling us that, I'm trying to put that into English.
Sure. I'm saying holding everything else constant for a second. So supposing all these other things stay constant, which of course there's some issues with making statements like that, but let's just leave that as is for now. So with everything else held constant, moving from no treatment to treatment, if I'm looking at a particular moment in time, I'm going to increase the risk of the event by that 1.2 multiple.
And it's not significant, but in this instance, it suggests that the treatment may be having a deleterious effect.
Yes, so it's not significant here. However, at least it's in a direction that would the sign of the estimate is making somewhat sense, which is is actually not is actually sorry is actually not good, because it's actually going to be increasing your your risk of the event, which is actually, you know, one may argue about p-values and statistical significance, but another question is, you know, just the sign of the thing is the sign of your estimate in a direction that you'd be moderately happy with, and here it's positive, which is meaning that it's having this potentially deleterious effect, which is again not great. Now, of course, one doesn't want to over interpret a positive sign when you have a non-significant p-value, but it's not a great thing to see here.
Okay. So continuing this conversation about how to make sense of the results that come out of this kind of analysis, craving 0.4234. So can you tell us what that number means? And you may be about to say, well, it's another log relative risk, but it's on a different, it's not a 0-1 variable. So
exactly.
It looks like it's on a scale from 1 to 11.
Yeah, so this is exactly right. So now this coefficient has to be interpreted in the context of what we expect variation in craving. So if everyone in the study is reporting craving between 8 and 11, of course that means that, you know, so this coefficient 0.4234 is with a single unit increase in craving, what the adjustment to your relative risk will be. However, this goes to the question, I think, a little bit more to your question. If craving is not highly variable within a participant, meaning the craving is staying within each participant at 3 or 4 or 5, then this relative risk is more across people. But if we're seeing craving change over time, then this is at least telling us that if we can impact craving, we can have a potentially large impact on the risk at any given moment. So if we can lower craving from 11 to 3 by providing an intervention, then we're going to see, so that's a 8 times 0.4234, which is quite large change in your relative risk.
Right. Now, so from this conversation, it sounds like we can interpret the coefficients here in the same way that we would interpret coefficients from a standard Cox regression output. They're log hazard rate ratios, which are generally interpreted as log relative risks. Is that an accurate assessment?
I'd say so. I think the main thing is to keep in mind is that the interpretation when you talk about holding everything else constant becomes a little bit more difficult to say, because you know, if I make an adjustment to craving, there's a joint relationship between craving and negative affect, and so one needs to understand how those how those things vary together to have a full picture of what's going on. But at least in terms of understanding the output of this one component of the model, you're absolutely right that you can do so. But you know, if with a drop in craving we also see a large decrease in negative affect, then the impact of a treatment on craving actually might have a joint impact on both, which is actually going to even further reduce the risk.
You've talked about 3 general models, a joint model, random sampling method, and the third one that I don't have a really good label for. We saw in this case, this is output, I think, from the randomization-based method.
Yes.
How would the interpretation of the point estimates differ across those 3 methods that you presented?
Great question. So assuming for a second that so I think it should come back to more what assumptions one is making when building these estimates. So the interpretations will stay relatively similar. The point I was trying to drive home was with joint models, method 1 I was calling it, one is assuming that this is a good model for the dynamics that you're observing. So in a traditional biostatistics trial in which there's a single biomarker, you're measuring it once a year, and you know, it's relatively smooth, one might feel confident in building a good model for those trajectories, and then you can have the similar interpretation. The issue is in mobile health, and the reason method 2 is appropriate in a lot of settings is we typically don't feel as confident in models for very complicated, in this case, 5-dimensional time-varying longitudinal data sets. And so in that situation, the method 2 is actually making much more minimal assumptions about, it's not actually writing down a particular model for how things vary over time. And so that's the benefit of the approach. However, it does require certain assumptions around how you collected your data, which may not hold in many situations.
Right. Given that the coefficients are interpreted like a standard Cox regression model, can we also say that we can use standard methods to assess improvement in fit or goodness of fit for these kinds of models?
Yeah, I think that there's some issues around how to, you know, goodness of fit around the survival models, yes, but then there's a question of goodness of fit around the models for the dynamics as well that you need to think about. So that's the sort of added complexity of the joint modeling approach is you need to have both assessment of model fit of the survival model as well as the longitudinal model.
Okay, that makes sense. You've got z-scores reported on this slide and also on slide 33. Are z-scores always going to be an appropriate tool for evaluating these estimates? Are there circumstances where they shouldn't be used?
Good question. I'm trying to think of situations in which they are.
Like if I have a limited number of participants.
Yeah, I mean, I think this is, you know, this comes back to sample size issues around when you're running a study. The only thing I would say, and I'm just trying to think through if this is the case. Yes, so even in the randomization-based one, this is based on asymptotic theory, and so if you have a very small sample size, feeling confident in your z-scores is going to be a problem. Even though this is randomization based, the estimator and the actual z-scores are all asymptotic statements, and so if you're looking at a sample size 20, I'd be a lot more hesitant to be thinking about them in that way.
Is there an alternative to the z-score in those circumstances?
I would say that the one not typically. I think in many situations you're sort of reliant on collecting a little bit more data to inform it, or using Bayesian methodologies to build informative priors and trying to move to a more Bayesian approach, which you can do in different settings. It's just a question of, with small sample size, how confident can you feel about any of your estimates for the association?
Right. More data is always better.
Exactly.
Yeah. All right. This has been a very good discussion. I appreciate the time that you've taken. We've had a lot of questions, some of them rather sophisticated, coming in through the WebEx, and we just don't have time to get through them. What I hope you would do is let us send you the questions that we've received that we haven't been able to raise in the conversation today, and you could develop brief answers, and we can post that, the questions and the answers on the website in about a week when we put up the slides and the video.
No, that sounds fantastic. Yes, I think my goals had been to sort of give a high overview of how these all components relate. So any particular questions related to more advanced methods, I'd be happy to answer and have it accompany the slides.
Okay.
Thank you, Dr. Murray, and thank you to everyone who participated in today's webinar. As I mentioned at the beginning of the webinar, we will be posting the slides and a recording of today's session on our website next week. You will receive an email with a link to the recording when it is available. Thank you.